Thank you, Michelle, for the introduction. My name is Tala Abedalqader. I am a recent graduate from Alfaisal University in Riyadh, Saudi Arabia, and I will be discussing a rare case of complicated appendicitis that presented to a hospital in Saudi Arabia. Right, so to start, we'll give a short overview of acute appendicitis. Acute appendicitis is defined as an acute inflammation of the appendix, and it is one of the most common surgical presentations in the emergency department with an incidence of around 10 cases per 100,000 population. It most likely occurs due to affection of the lumen of the appendix, and that can be due to a fecal lift, a normal stool, infected agents, or lymphoid hyperplasia. The incidence of acute appendicitis increases as the age group increases, and it peaks in the late teens. There's a slight male preponderance with a ratio of 3 to 2 in teenagers and young adults. Acute appendicitis typically presents with acute onset of abdominal pain, which is the most common presentation, and it is typically in the right lower quadrant with a history of migration from the peri-umbilical region, and it could be associated with nausea, vomiting, anorexia, and diarrhea or constipation. So for our case presentation, our patient is a 20-year-old male who is a known case of diabetes mellitus type 2 on metformin. He presented to the emergency department at Prince Hamad bin Abdulaziz Hospital in Riyadh, Saudi Arabia, with history of right lower quadrant pain for 3 days. The pain had begun in the peri-umbilical region and then had localized to the right lower quadrant, and it was associated with fever, subjective, not measured, vomiting, anorexia, and dysuria. There is no associated change in bowel movements, diarrhea, jaundice, clear icterus, changes in urine output or color, or flanking. Past medical history was significant only for the diabetes. Past surgical history was significant for vertebral fixation 3 years prior, with no history of abdominal surgeries. Medication history was significant only for metformin, which he was taking regularly for his diabetes. Family history and social history were unremarkable. Now, on examination, the patient appeared to be in distress due to pain, but was otherwise vitally stable. His eye examination showed no scleral icterus or pallor. Oral examination showed moist mucous membranes with good hygiene and no ulcerations. His chest and cardiovascular examinations were within normal limits. An abdominal examination showed right lower quadrant tenderness with a positive Robson sign, positive rebound tenderness with no rigidity or palpable masses, and his soil sign was negative. Musculoskeletal and skin examination were within normal limits. Now, some labs were ordered for the patient while he was in the ER. They showed no elevation. His CBC showed no elevation in his WBC count. It was at 7.25 times 10 to the power of 9 per liter. And all his white blood cell subtypes were also the normal limits. His hemoglobin and his counts were also within the normal range. His hepatic immunoprofiles were unremarkable, and the C-reactive protein and inflammatory marker was also within normal limits. A CT scan was ordered for the patient, a CT scan of the abdomen with contrast. The findings were consistent with the diagnosis of early acute appendicitis. So the CT scan showed an appendix caliber measuring around 7 millimeters with minimal fat stranding, seen here in the green circle, and small mesenteric lymph nodes indicated by the blue arrows. The solid abdominal organs appeared unremarkable, and there was no free fluid or free air noted in the scan. Now, the patient was admitted as a case of acute appendicitis and planned for appendectomy. He was kept NPO for 8 hours prior to the surgery. Intravenous fluids were started, and he received paracetamol as analgesia. He received prophylactic antibiotics before the surgery. A laparoscopic appendectomy was performed under general anesthesia, and it proceeded smoothly with no complications. The surgical specimen was then sent for histopathology, and that will be discussed in the next slide. Post-op, the patient was started on thermal prophylaxis with heparin. He had no complications and had started to tolerate orally on post-op day 1 with no nausea or vomiting, and he was mobilizing well. The surgical scar was clean with no erythema or discharge, and the patient was discharged after 3 days of hospitalization with a scheduled follow-up after 2 weeks. Now, the histopathology. So the surgical specimen was received in formalin labeled as appendix and consisted of an intact appendix measuring 10 centimeters by 1 centimeter. On gross examination, the appendix had a congested outer surface and a focally dilated lumen with hemorrhagic mysterium. On histological examination, the appendix showed granulomatous inflammation was visualized on a background of acute appendicitis. The sections of appendiceal tissue showed multiple granulomas in multiple layers of the appendix, in the mucosa, muscularis, propria, and subserosa, with a background of neutrophilic infiltration. Most of the granulomas were ill-defined. However, there was one granuloma that was well demarcated with an aggregate of affiliate histocytes, and an accompanying giant cell reaction was noted with no central necrosis. And this is a picture of the well-defined granuloma that was found. There was no evidence of inflammatory bowel in the examined material. So based on the histology, the patient was labeled as having granulomatous appendicitis. So to talk a little bit about granulomatous appendicitis, it is a rare inflammatory condition that affects the appendix and has a reported frequency of less than 2%. The pathogenesis or the underlying mechanism of this condition can include a wide range of possible etiologies, including infectious or non-infectious conditions. The presentation of granulomatous appendicitis mimics the presentation of acute appendicitis, as we saw in our patient, with an ordinary range of inflammation. Patients typically present with fever, nausea, vomiting, anorexia, and abdominal pain. After the patient is identified as having granulomatous appendicitis, it is important to obtain a thorough person history and physical examination, and those will be important parameters to aid you in the diagnosis of granulomatous appendicitis. So the causes of granulomatous appendicitis can be characterized or classified as infectious or non-infectious causes. Infectious causes include bacterial infections such as Yersinia species, Mycobacterium tuberculosis, Actinomyces species, or parasitic infections such as infection with Enterovirus vermicularis, as well as fungal infections. Non-infectious causes can cause a wide range of diseases, as diverticulitis, foreign body granulomatous reactions, tumors, and inflammatory or autoimmune conditions such as sarcoidosis and inflammatory bowel disease. Specifically for inflammatory bowel disease, the important subtype is Crohn's disease in this case, and it can manifest in one of two types. Number one is appendiceal Crohn's disease, in which the inflammation is limited only to the appendix, or number two is appendiceal involvement of Crohn's disease, in which the inflammation is located in the ileum or cecum, and then it spreads to the appendix. Other causes of granulomatous appendicitis include delayed appendectomy after perforated appendix that has been treated with conservative management. And lastly, a very rare cause of granulomatous appendicitis is idiopathic. Now back to our patient. So after he was identified as having granulomatous appendicitis in his pathology, the patient presented back to the general surgery clinic after 2 weeks for his follow-up. He was found to be in good condition. He was not complaining of any new symptoms, and he had well-healing surgical scars with no discharge or edema. But because we had now a reason to obtain a more thorough history, that is exactly what happened. So on further questioning, the patient denied any weight loss, night sweats, recurrent fever, or fatigue. He denied dizziness, loss of consciousness, changes in vision, or scleral icterus. He had no shortness of breath, cough, hemoptysis, palpitations, or chest pain. no changes in bowel movement, diarrhea, fecal stools, hematopoiesia, and no changes in urine output or color, flying pain, or hematuria, and he had no skin changes, rashes, or extremity pain or joint pain. Now, it is important to think about the causes of the possible etiologies of granulomatous appendicitis as you are obtaining history from the patient and as you are performing the physical examination. So you are looking for signs of the underlying conditions. So for example, for TB, you want to ask about, or one of the symptoms that you ask about is weight loss, night sweats, shortness of breath, cough, hemoptysis, and so on. Physical examination showed no evidence of fever, dehydration. He had no pallor, aphthous ulcers that could suggest corroded disease, no cranial nerve palsy that could suggest sarcoidosis. He had no evidence of extraintestinal manifestations of IBD or of sarcoidosis. So he had no uveitis, scleritis. He had no evidence of tachycardia, wheezes, raves, or crackles. And there was no evidence of skin changes, rashes, joint effusions, or cranial fistula, stags, or ulcers. Now, for the diagnosis of granulomatous appendicitis, as we saw in our patients, the confirmatory diagnosis of granulomatous appendicitis is made by pathology. That happens following appendectomy and examination of the specimen under the microscopy. So macroscopically, before we go into the microscopic features, macroscopically, the appendicular inflammation can be classified as normal, inflamed, phlegmon, gangrenous, or perforated. And this can be seen either in acute appendicitis or in granulomatous appendicitis. There are several growth characteristics that can help guide the diagnosis of granulomatous inflammation, such as a nodular appearance or an abscess-like appearance or the presence of adhesion. Now, on histopathology is characterized by the presence of non-necrotizing granulomas consisting of epithelioid and multinucleated giant cells as well as inflammatory infiltrate. Additional diagnostic tests should be aimed at identifying the underlying etiologies. So, for histopathology, you can perform some tissue diagnostic studies such as acid vascular stain, PPD test, and interferon gamma release assays, and these can be used to diagnose tuberculosis. Periodic acid shift stain or fast stain can be used to detect fungal elements in the tissue, and tissue culture and tissue PCR can also help aid in diagnosis. Now, all of these tests were negative in our patients. Some further diagnostic studies that can be ordered, it can include laboratory studies and imaging studies. For laboratory studies, it starts with the basic lab on complete blood count can be used or can give clues as to the underlying mechanism. For example, you might be able to see leukocytosis with IBD or with sarcoidosis, and an increase of one of the subtypes can also help guide you in the right direction. So, for example, you might see eosinophilic and fungal or bacterial infections. Renal function tests and electrolytes can help detect hypercalcemia and hypercalciuria, which is typical for sarcoidosis. Hepatic function tests can also help further guide the diagnosis. You can have hepatic involvement in or biliary involvement both in IBD and sarcoidosis, and an elevated alkaline phosphatase level could suggest hepatic involvement of sarcoidosis specifically. Some patients with IBD can present with vitamin level deficiencies, specifically the fat-soluble vitamins such as A, D, E, and K. Vitamin D elevations could be seen in sarcoidosis, and you could also use inflammatory markers such as ESR and CRP, and that can help you guide you to a diagnosis of inflammatory condition. Some serologic studies like anti-saccharomase, cerevisiae antibody, and anti-nucleic cytoplasmic antibodies can be helpful in the diagnosis of IBD. PD studies like the PPD or the interferon gamma release assay can help diagnose microbial infections, and stool studies can be used for the diagnosis of IBD. For imaging studies, chest X-ray, a chest X-ray or CT scan of the chest can help you diagnose sarcoidosis. CT scan of the abdomen or MRI of the abdomen can help you detect abnormalities within the GI tract to diagnose IBD, and MRI specifically can be used to visualize fistulas, and colonoscopy can be used to visualize the colonic mucosa and to biopsy the mucosa in order to diagnose IBD. Now, your choice of diagnostic studies depends on what the patient presents with. So it depends on the comprehensive history and the physical examination that you obtain from the patient. So our patient had a negative review of systems, and his physical examination was unremarkable. Additionally, his CBC renal function test, hepatic function test, and his inflammatory markers were all negative. And that was seen when he was admitted in the emergency department. And there were no abnormalities detected on CT scan of the abdomen. So we elected not to proceed with any other laboratory and imaging studies. And instead, we recommended regular follow-up for the patient and to basically present to our clinic if should he develop any concerning symptoms. So the management of granulomatous appendicitis, appendectomy is a curative treatment. Further treatment should be administered to patients based on the underlying mechanism of disease. So, for example, if the patient had been found to have mycobacterial infection that had been causing this granulomatous reaction, he would have received anti-bleeding medication. Similarly, corticosteroids or immunosuppressors can be used in the management of inflammatory bowel disease or sarcoidosis. And surgical management can also be considered in the management of IBD, for example. Like I said, regular follow-ups are recommended, and this is recommended for all patients, not just our patients. So whether the patient did have positive findings in his history or physical examination, or if he did not have, regular follow-ups are recommended in order to monitor the disease progression and treatment effectiveness if the patient has been receiving the treatment. And in addition, regular follow-ups can help in detection and management of complications of infectious or systemic diseases that are associated with granulomatous appendicitis. So if you diagnose the complications early, you can treat them early, and the patient has better prognosis overall. Now, the significance of the study is that although granulomatous appendicitis is rare, it is important to recognize, diagnose, and treat the etiology as early as possible in order to improve the prognosis of the patient. A few cases have been reported around the world, and this is the first case that has been reported in Saudi Arabia. In conclusion, granulomatous appendicitis is an uncommon subtype of appendicitis with multiple possible etiologies, including infectious and non-infectious causes. The curative treatment is surgical incision, and confirmatory diagnosis is made through histological examination of the surgical specimen. And again, although it is uncommon, it is very important to obtain a comprehensive history and physical examination in order to identify possible underlying etiologies and help further guide the diagnostic studies and management options. Treatment should be tailored according to slow progression and prevent recurrence and complications of the positive disease. And it is very important, again, regular follow-up for the patient. This is the case report published on Curious. You can find it also on PubMed if you would like to read it on time, and these are the references I use. Thank you for listening. Any questions?